Greetings, everyone. It's a great pleasure to come to you today. And it's the exciting part of an elderly professor's career to have two distinguished colleagues that are both world famous be able to join me in presenting a video and to take what I have done and carry it to the next level. This is just absolutely incredible, and I can't say enough about this. And I would tell all of you out there, this is a must view for anybody that ever takes care of a hospitalized medical patient. And today's presentation is going to be done by Alex Spyropoulos, who's professor of medicine at the Donald and Barbara Zucker School of Medicine at Northwell Health System in New York. He's also a professor at the Institute of Health Science at the Feinstein Institute for Medical Research, as well as the professor of the Emeritus Graduate School of Molecular Medicine and system director, this is really key, of the anticoagulation and clinic thrombosis services at Northwell Health Systems in New York City in the United States. He is probably the leading authority in the world for medically ill hospitalized patients involving risk assessment. So it's really a wonderful thing to have Alex with us. And then in addition, I have another distinguished gentleman who's a dear friend, a colleague, and an unbelievable physician who I've had the good fortune to have take over my practice and again, take it to the next level. And the other thing is that I think for all of you out there, I have a message. We all get passionate about certain things, but you must make sure that you keep your ears open, because the song you are singing, if you keep singing it over and over again, you tend to believe it. And it may not be the right song. But thanks to these gentlemen, they've listened to me singing and they have adjusted the tune as we go forward. And helped all of us to grow and I'm glad all three of us are on the screen together, because this illustrates that life is a team sport. And it's not about one or the other, but what about the goal? What's the goal? The goal for all of us is to improve healthcare around the world and cut down on fatal pulmonary emboli. And before we get started, I would like to have a very special dedication of this video, and that is to David Rosenberg. And I wondered if, Alex, you could say a few words about this wonderful man who died much too early and all the work he had done.
Yes, thank you, Joe. And before I do that, I just really want to tell you, as I've said actually in the video, it's a real privilege, Joe, to be speaking for you, who I consider one of the founding fathers of surgical thromboprophylaxis. So a real privilege for me to have this discussion on medically ill thromboprophylaxis. And also, it's a really a nice privilege talking with Alfonso, who I've really respected over the years in terms of his work as well. So as you said, this is a team sport, and a real privilege to be on this team. And as I look at the face of David Rosenberg, it's surreal. I can't believe David is no longer with us. But David, in addition to being a dear colleague, he was also a dear friend. Yeah, he was the first division chief of hospital medicine for North Shore University Hospital. I met David when I came into Northwell nearly 13 years ago. And with me, he was one of the first co-chairs of the multi-institutional, multidisciplinary clock council at what became Northwell Health. And he really helped me and the system to implement evidence-based VTE thromboprophylaxis strategies, whether they be in surgical or medical patients. And he was a key driver of some of our early work on thromboprophylaxis quality initiatives and also randomized clinical trials. So again, David Rosenberg was a dear colleague who will be missed and left us all too soon.
Thank you very much, Alex. I also happen to know him, and his warmth was just incredible. that that he had, and I think that it's really a wonderful thing to be able to dedicate this video to him. Now, before I show the video, I want to remind all of you, do not get lost in the weeds. And I urge you not to do what most people that look at YouTube, they look at it for a couple of minutes. This is a real anthology, and it traces medical risk assessment progress. And there's three things at the end of this that you need to take away and never forget, because they are the pillars of lowering the incidence of fatal pulmonary emboli. They are individual risk assessment, initially through the hospitalization, and then repeated scoring at discharge, because most of the patients that get a clot will get it after they leave the hospital, and they need anticoagulant prophylaxis on an ongoing basis. And using this score, there's some very good data that testify to that principle. The third thing is implementation of the evidence-based pathway. It's wonderful to collect all this data, but characteristically, doctors don't like to be told what to do. So when you say this protocol will save lives, you've got to do it, everybody gets their ears and their hair up in a rumble. So that we have to have subtle links to how to implement with nudges these mandatory risk assessment profiles in order to lower the incidence of venous thrombosis. So I hope you all enjoy the video, and afterwards we'll have a short discussion. Thank you very much.
Hello, I'm Alex Spyropoulos, Professor of Medicine at the Zucker School of Medicine and Professor of the Institute for Health System Science, as well as System Director of Anticoagulation and Clinical Thrombosis at Northwell Health in New York. I'd like to thank Dr. Joe Caprini, who I consider one of the founding fathers of surgical thromboprophylaxis, for the invitation to his podcast. I'll be discussing a topic that I've spent the better part of 20 years of my academic medical career studying, namely post-discharge extended thromboprophylaxis in hospitalized medical patients. These are my disclosures. And by way of introduction, there are an estimated 20 million acutely ill medical patients that are at risk of venous thromboembolism, or VTE, that are hospitalized each year in the US and European Union, although these are likely underestimates. They account for over 400,000 VTE and fatal PE events and represent 22% of all VTE events. Indeed, in the hospital, the majority of symptomatic VTEs and up to 80% of fatal pulmonary embolic events occur in acute medically ill non-surgical patients. So this is a major problem worldwide. There continues to be a significant unmet medical need for VTE prevention in this population, including in the post-discharge period. About 25% of these patients are at high VTE risk, but thromboprophylaxis continues to be missed and underutilized. And as we'll see, the rate of symptomatic VTE more than doubles over the first 3 weeks post-discharge and is associated with a 5-fold increased risk of fatal PE within 45 days. We know from landmark placebo-controlled trials that were conducted over 20 years ago that inpatient thromboprophylaxis works, associated with a 50 to 60% reduction of total VTE in medically ill patients. However, this was during the time that the average duration of hospitalization was 7 to 14 days. Move forward about 20-25 years, and the average length of stay in the United States for this patient population is closer to 4 to 5 days. We also have more recent data conducted in the last 10 to 15 years showing that the risk of VTE extends well beyond hospitalization in medical inpatients. As we see here, the risk increases sharply in the first 3 to 4 weeks post-discharge and plateaus at about 4 weeks in the post-hospital discharge period. Indeed, nowadays, we see that in high-risk elderly medical patients, the vast majority, up to 80% of VTEs now occur in this immediate post-hospital discharge period. So we can conceptualize 3 periods of VTE risk in medically ill. The acute hospitalization period, which represents the highest VTE risk period, but for which more and more the minority of VTE events are occurring. the immediate post-hospital discharge period, which still represents a high VTE risk period. And as we'll see, more and more the majority of VTE events are occurring, especially in elderly patient populations, and in about 10% of medically ill patients with chronic medical illness, such as those in nursing home and other facilities. And by far, the universal standard of care is formalized VTE risk assessment in this population only at admission, using either group-based or universal prophylaxis strategies, with no formalized VTE risk assessment at discharge, and of course, no formalized assessment in long-term care or nursing home facilities. In 2025, we now have a good grasp of some of the key VTE risk factors in hospitalized medical patients that contribute to high risk of the disease: a prior history of VTE, acute infection, and we all appreciate the very high rates of thrombosis seen in the early phases of the COVID-19 pandemic, as evidenced by an entity that we now call thromboinflammation, malignancy, advanced age, presence of congestive heart failure, stroke, or prolonged immobility, as well as ICU stay. These all contribute to a heightened risk of VTE. Also, a relatively new biomarker, an elevated D-dimer, is also able to predict high risk of disease as well. We also have now two well-validated VTE risk assessment models, the PADWA model seen on the left and the IMPROVE model on the right. Both contain clinical risk factors that are weighted and scored from 1 to 3 points. In the PADWA model, a score of 4 or more predicts a high VTE risk population that benefits from in-hospital thromboprophylaxis, whereas in the IMPROVE model, a score of 2 to 3 predicts a moderate risk population that benefits from in-hospital thromboprophylaxis, whereas a score of 4 or more predicts a high VTE risk population that benefits both from in-hospital as well as extended post-discharge thromboprophylaxis. More recently, an elevated D-dimer was added to the original IMPROVE model to create the IMPROVE DD score, which improves the original model of discrimination. The various trials of the direct oral anticoagulants, or DOACs, for extended thromboprophylaxis in acute medically ill patients had mixed results. The ADOPT trial that tested apixaban 2.5 milligrams twice daily did not show efficacy of apixaban, but conversely showed a 2.5-fold increased risk of major bleeding. The Magellan trial was the first of the DOAC trials that showed efficacy with rivaroxaban at the 10 milligram dose, leading to an approximate 23% risk reduction of total VTE, but this came at a price of a nearly 3-fold increased risk of major bleeding. The APEX trial also showed efficacy with betrixaban with no excess major bleeding, although this DOAC is no longer available. And the Mariner trial, the largest trial in the field of which I was privileged enough to be the co-principal investigator, testing 2 doses of rivaroxaban, 10 milligrams and 7.5 milligrams, although showed a decrease in symptomatic VTE and fatal VTE events, this reduction was not statistically significant. However, pre-specified secondary outcomes showed a 56% reduction in symptomatic VTE and a 27% reduction in symptomatic VTE and all-cause mortality. And much like the APEX trial, the Mariner trial did not show evidence of excess bleeding, where major bleeding events were few and far between. So the totality of data of extended thromboprophylaxis in unselected medically ill hospitalized patients tells us that such a strategy in essence is robbing Peter to pay Paul. In other words, a strategy of extended thromboprophylaxis reduces symptomatic VTE and VTE-related death by 40%. However, this comes at a price of a more than a 2-fold increased risk in major and fatal bleeding. Hence, moving forward, the key aspect of this is to be able to identify a low bleed risk and high VTE risk population that significantly benefits from extended thromboprophylaxis. Indeed, our group conducted such an analysis from the Magellan database, and what we found is if we were able to select 5 key bleed risk criteria that excluded 20% of the overall population, namely no dual antiplatelet therapy, no active cancer, no bronchiectasis, or history of GI bleeding, or history of bleeding within 3 months of the hospitalization. What we did is we were able to identify a low bleed risk population, and as long as we were able to incorporate the IMPROVE score plus elevated D-dimers using a cutoff of a score of 4 or more, we were able to predict a nearly threefold higher VTE risk group of patients in this low bleed risk population that significantly benefited from extended thromboprophylaxis, with an approximate 36% relative or 2.6% absolute risk reduction of total VTE, again, with no evidence of excess major bleeding. We also found in a pre-specified analysis of Mariner that the 10 milligram dose of rivaroxaban was able to reduce not just symptomatic VTE, but major and fatal vascular events that included myocardial infarction, stroke, and cardiovascular death by about 28%. So in these low bleed risk and high VT subgroups, then a strategy of extended thromboprophylaxis has net clinical benefit across all vascular endpoints, including not just venous thromboembolism, but arterial thromboembolism as well. And on the right, we see that such a strategy is actually more robust across time, so that the longer one receives extended thromboprophylaxis, the greater the net clinical benefit. Indeed, for total VTE, the number needed to prevent one event is 55, whereas the number needed to harm to incur one major bleed event is 560, a 10-to-1 ratio. And what are the populational health implications of such a strategy in these populations? Well, we're able to prevent 20,000 fewer VT events and 12,000 fewer VT-related deaths at a cost of 1/4 of those in major and fatal bleeds. And because of this, the most recent VTE guidelines, the updated 2024 International Consensus Statement guidelines, have for the first time given a recommendation based on moderate level of evidence that formalized VT risk assessment should be considered at discharge, and a strategy of extended duration thromboprophylaxis with either low liquid heparin and exapirin 40 milligrams once daily, as shown by analysis of the Exclaim trial, or rivaroxaban at the dose of 10 milligrams daily, as I just showed you, for approximately 30 days may be considered on an individualized basis, namely using the IMPROVE DD score and a cutoff score of 4 or more, as long as patients are at low bleed risk. However, now that we've identified low bleed risk and high VT risk patient subgroups of hospitalized medical patients that benefit from extended thromboprophylaxis, the key is how do we implement such strategies? We've known from data that is nearly 20 years old that the use of health informatics technology in the form of either electronic or passive alerts has the ability to improve appropriate thromboprophylaxis in hospital and, at least in one study, decrease the rates of symptomatic VTE. However, we know that these passive alerts have potential to lead to alert fatigue, and also these informatics technologic systems had the inability to be used across EHRs. We now live in a much more sophisticated informatics technology environment with the use of HL7 and Smart on Fire standards that produce EHR agnostic active clinical decision support systems that have the ability to greatly enhance implementation of clinical decision support. Our academic informatics group at Northwell was able to create such a novel EHR agnostic platform, which we call Evidence Point. This enables cloud-based integration, the EHR integration overview shown in this slide. Users are able to launch a particular CDS tool from a typical EHR workflow. The CDS tool then forwards the request to the Evidence Point application programming interface that we see here, which then retrieves the patient's data from the EHR data backend or using the Health Informatics Exchange environment. The user then fills out any remaining information, and the tool then calculates a personalized risk score based on a particular CDS tool for the patient, which in turn is sent back to the EHR, which is then incorporated into the patient's medical record, as well as the ability to trigger any resulting next steps in the EHR, such as operating an order set. This is a schematic of the flow between the healthcare system, electronic health record, and health informatics exchange. We see here our Evidence Point platform sits on top of a EHR, such as it being in a health informatics exchange environment. A particular CDS tool is launched from the EHR, calculations are made, then the results are sent back to the EHR, which in turn send either recommendations, order sets, and populate a provider note. This is able to be used in any healthcare environment, whether it be the ED, the OR or cath lab, radiology suites, or inpatient setting, and is able to also to be incorporated into a clinical care pathway. One of the first CDS tools that we used within our evidence point platform was the IMPROVE DD VTE tool that is depicted here. This was launched within 3 established clinical workflows in our EHR. When the IMPROVE DD tool was launched from such a clinical workflow, the answers to the 8 clinical and laboratory risk factors as per the tool were pre-populated based on existing patient-specific data in the EHR. Or the user was able to also manually adjust the individual risk factors as well, such as, for example, the mobility criteria. When the user clicked Calculate Probability, the IMPROVE DD score and the 3-month VTE risk percentage were displayed. And when the user clicked Record Results and Proceed, the tool closed, the IMPROVE DD score was written into the EHR. Again, low risk for green, moderate risk for yellow, and elevated or high risk for red. And an appropriate prophylaxis recommendation was displayed in the EHR. This is an example of how the IMPROVE DD tool was incorporated into our EHR. This is using a brand new workflow, namely a workflow at hospital discharge within the medication reconciliation environment. And we can see here that the tool was launched from a particular button, and depending on whether a IMPROVE DD threshold score was reached, in this case a score of 4 or more, then a VTE extended prophylactic recommendation was made within the EHR, in this case the use of rivaroxaban 10 milligrams daily. And again, this is important as this was part of the medication reconciliation process. We then obtained funding to conduct a large cluster randomized trial to test the effectiveness of our clinical decision support tool using the IMPROVE DD VTE score. We were able to obtain funding, and ultimately we randomized 2 hospitals using this CDS tools within the clinical care pathways, as I mentioned, and randomized 2 other hospitals within our Northwell Health system to usual medical care. All providers were educated on the use of the IMPROVE DD tool, and the primary outcome was appropriate thromboprophylaxis based on the IMPROVE DD score thresholds, 2 for at-risk and 4 or more for high risk. And secondary outcomes included clinical outcomes such as thromboembolism and major bleeding. Ultimately, we were able to randomize nearly 10,700 medical inpatients into our cluster RCT, which represented about 5,000 patients per hospital. What we saw at the end was that the tool had extremely high adoption, nearly 78% adoption, showing its high usability. And also, the trial met its primary endpoint. What we saw in the hospitals using the CDS tool was an over 50% increase in the rate of appropriate in-hospital thromboprophylaxis, usually using a heparin such as unfractured heparin and low liquid heparin, and a near doubling, a 93% increase in the use of appropriate extended thromboprophylaxis in high VTE risk patients, those with an IMPROVE DD score of 4 or more, mainly with the use of rivaroxaban 10 milligrams for up to 30 days. And what did these change of behaviors lead to? Well, they led to a decrease in hard outcomes. We saw an approximate 30% decrease of total thromboembolic event rates, which included a 20% reduction in venous thromboembolism and an over 60% reduction in arterial thromboembolism, with no increase in the rates of major bleeding. So, for this and other reasons, the same updated 2024 International Consensus Statement Guidelines gave a moderate recommendation based on moderate level of evidence that the use of health informatics technology in the form of either electronic alerts or clinical decision support tools may be considered to identify key populations of medically ill patients that may benefit both from in-hospital as well as extended post-discharge thromboprophylaxis. So to conclude, dear colleagues, we are entering what I like to call a new paradigm in medically ill thromboprophylaxis, an individualized, patient-level VTE risk-adapted approach with the use of clinical decision support and electronic health record interoperability in those health systems that have these types of systems. The acute hospitalization period represents still the highest risk period, and we should still continue formalized VTE risk assessment at admission, but we should be moving away from a universal or group-based strategy and moving towards a more individualized VTE risk assessment approach, either using individualized VTE risk factors or better yet, a validated VTE risk model such as PADO on IMPROVE, and depending on whether threshold scores VTE scores are reached, provided that the patient is at low bleeding risk, they should be offered inpatient thromboprophylaxis, usually with unfractionated heparin or lone liquid heparin, as well as the potential use of fondaparinux and rivaroxaban as it is FDA approved as second-line agents. But we should be moving towards also formalized VTE risk assessment at discharge for this patient population as well, especially in U.S. health settings with a length of stay of 4 to 5 days for this patient population. And if patients meet a threshold risk, either using high individualized VTE risk factors such as advanced age or prior history of VTE or cancer, or better yet, using a validated VTE risk model such as IMPROVE or IMPROVE DD, and if a threshold score is reached, in this case a score of 4 or more, and the patient is at low bleed risk, they should be offered extended thromboprophylaxis with, at this point, rivaroxaban, the 10 milligram dose for 30 days as it is FDA approved. In my view, this will have tremendous populational health implications in reducing the burden of VTE in this very fragile patient population. Thank you.
Now that we have viewed this, I think you'll agree that this was a magnificent presentation that really traces inch by inch. And it shows a characteristic of Alex, for example, who is a master at designing trials, designing ways to prove the points that he's trying to prove. And I'm so excited today, too, because my partner who took over my practice is one of the most sophisticated, knowledgeable people regarding the statistical analysis of risk assessment trials. And Alfonso Tafur is a clinical professor of medicine at the University of Chicago Pritzker School of Medicine. He's director of the cardiovascular research and vascular medicine at Endeavor Health, which is a former North Shore University health system, which I think we borrowed from New York, but I'm glad that we gave that title back to you because you guys deserved it. And he holds an MBA as well from the University of Loyola Quinlan School of Business, which reflects his depth of knowledge in healthcare strategy and a deep-rooted commitment to healthcare. He's an international leader in research and clinical principles of vascular medicine, especially venous thromboembolism. And here's the 10-ton elephant in the room. Given the chance, Alfonso and others like him will tread the very delicate balance between cost effectiveness and effective patient care. And I think that we need this because without it, we can't let the administrative side of medicine just run unhinged, but it has to be balanced with physicians who are willing to use their knowledge of business to help balance this. So it's a great pleasure to have Alfonso here. And Alfonso, would you begin the discussion by addressing your question to Alex?
Yeah, thank you, Joe, very much. I mean, it was a beautiful video, beautiful historical trajectory on how to make our patients better after we leave them, right? So after we already did the things that they needed in the hospital, it is unfair they continue to have this Damocles sword of the potential thrombotic event. But historically, and looking into this trajectory of economics that Joe was mentioning, we're using now a thrombotic score. And the beautiful surprise you've taught us is that this reality of using anticoagulation and right dose, right timing is not just a dual pathway strategy, it's a dual outcome benefit, right? Because you've proven to us there's a VTE improvement, there's an arterial thrombotic improvement. So my question to you is, what do you foresee for perhaps tailoring and optimizing the patients who may actually also benefit from some of the arterial thrombotic events in a future score or modified score, and the economical implications so that we can continue to partner, I would say, not battle, but partner with administrative sides so that the final battle of the economics of healthcare make sense to actually implement further these strategies.
Yeah, Alfonso, two very good questions, and again, thank you for inviting me to give this discussion. I think what I'll do is I'll tackle the second question first, and probably you more than anyone know that economics is local, right, and economics is regional. Also, we have not just the administrators, but we have the doctors on the ground saying, why should I do this? And how to make my life easier? If I have to use formalized risk assessment, how does it impinge my workloads as least as possible? So the answers to those questions are kind of two or threefold. The first is that we know that older health informatics technology was clunky, right? It was passive, and you couldn't use the results from one study, and you couldn't transfer it to another EHR. So it was not interoperable across EHRs. So from an economics perspective, you actually had to reinvent the system in a different locale, different EHR all over again, which was quite cost ineffective from an informatics point of view. So now with, as I mentioned, this HL7 and Smart on Fire based interchange technology, we're now entering the era of active clinical decision support, which means two things. Number one, within our cluster RCT, we use usability testing. We actually asked the doctors on the ground, where is the easiest point to implement this formalized VT risk assessment? And they told us at 3 points, during the H&P, during the medication order, and at discharge. And that's what we did. And that's why we found, number one, such high usability and high adoption, almost 78%. The second thing that we found is that the doctors were able to do this in about 10 seconds. So it actually made their lives easier because they were able to use an automated clinical decision support system that essentially auto-filled, in this case, the IMPROVE DD score within a 10 to 15 second time frame, which otherwise would have taken them about 5 to 10 minutes. And it was attached to an order set. So it wasn't enough just to tell the physicians that the IMPROVE score was such. What does that mean? So the fact that this was attached to an actionable item was actually, I think, a big plus. And also, from an economic point of view, it's exactly what Joe said, right? Is you attached a thromboprophylactic regimen to the right patient at the right time. That's basically what we showed. And then ultimately what we showed is this increase in appropriate thromboprophylaxis actually was able to reduce not just venous, but arterial side events. So from an overall administrative economic perspective, what we also saw that I didn't mention in the video, we were able to reduce, 30-day readmissions and able to reduce, things like arterial as well as venous events within that 30-day time frame. So this has a lot of implications from a quality perspective if I'm a hospital administrator. So that's actually the first point. So not only is it easy to use, not only does it change behavior in a better way, not only does it reduce hard outcomes, namely thromboembolism, but it leads to higher quality metrics at a health system level. So I think it's win-win-win. And then to answer your second question, what's interesting to me is that when we actually look at the Mariner and Magellan data, approximately 50% of this patient population, hospitalized medical patients, are on a background antiplatelet therapy. So we don't actually have to modify the score. What we have to say is that these patients who are already on background antiplatelets for usually another reason, whether it be congestive heart failure or other cardiovascular diseases, benefit from a dual pathway inhibition approach, which, by the way, when you add very low doses of a DOAC rivaroxaban, you actually not improve cardiovascular events, but don't incur excess bleeding. Very similar to the COMPASS concept, the COMPASS regimen, where you have ultra low dose rivaroxaban on top of single antiplatelet therapy, where you improve overall vascular effects without excess major bleeding. So what we've seen more and more as we move forward is, I think, Joe, you would agree with me that the separation of church and state that we had with arterial and venous thromboembolic events was somewhat artificial. That moving forward, we see a lot more similarities between the two disease states, although there are some subtle differences. And we have to be thinking of these two disease states in a much more holistic fashion, which means that in the future, when we conduct studies in venous thromboembolism, we have to also use arterial endpoints. And when we use this against a background of antiplatelet therapy, what we're finding is a holistic reduction in cardiovascular events.
Well, that was a beautiful additional dissertation. Alfonso, sorry, I didn't mean to interrupt you.
I was going to thank you, Alex, for a very comprehensive answer. I have to wonder if facilitating healthcare, reducing the burden of time of physicians on doing more things, really has a much more larger effect. Arterial events, venous events, better reduction of outcomes in the readmission rate, and overall physician well-being, if you're actually reducing the burden that it has to be otherwise for thinking about 20 scores at the same time.
That's exactly right. Hopefully, the promise of advanced informatics, Alfonso, that everyone has touted about for the last 20 years is hopefully very clear to us, that it will make physicians' time and burden easier, not harder. And the hope is that if this is the case, then actually not only we will do the right thing from a physician point of view, but it will lead to a reduction in hard outcomes. And I'd just like to say, the next step, hopefully, with respect to our clinical decision support tool, is widespread implementation. So we are, again, have applied for an R01 grant from the National Institute of Health to see if we can implement what we saw within the Northwell system to a much larger group of hospitals within the United States. And of course, with all of the nooks and crannies that we have to assess in terms of usability, in terms of the local healthcare environment, local economic environment, et cetera, et cetera. But the hope is at the next phase of this project is a wider implementation of the CDS tool.
Well, I think that was an incredible dissertation again on something that's really, really very important, and how to get everybody to use it. And what I glean from this, Alex, is it looks like you're going to have it so simple, and you're going to use 30-day readmission rates that the doctors will actually see their results, and thereby they'll say, I want to be part of the success of this program. And I think that we saw that with Boston University, because they've kept their surgical VTE rate at a very, very low level for over a decade, because after a while, everybody wanted to be a part of the success of the program. So I'd like to thank you both for participating in this discussion, and I would like to thank the audience for everyone who chooses to look at this, and I think you'll find that this is a great source of a material for you to maybe even look at over and over again in order to improve the results in your own area. Thank you very much again, gentlemen, and I hope you have a great day.